15-year-old Lucy has experienced regular, irresistible naps over the preceding years. Sleep, once friendly, has betrayed her. Now, when she meant to sit and work, sleep would creep up and take her by surprise. At night, when sleep was welcome, it would lull, bite, then desert her. And the sleeps which overtook her in the day were bizarre. She would be dreaming instantly, her perceptions as vivid, more vivid than those of waking life. It was becoming increasingly hard to distinguish her recollections of dreams from memories of wakefulness. The boundaries of sleep and wakefulness were breaking down. Lucy, normally quick to question the sanity of others, wondered whether this was how madness began. On one occasion, as she emerged from the dream, she had felt a terrible weight on her. Try as she could, neither her arms nor her legs would move, pinned to the bed by invisible bonds or paralyzed. Whilst bantering with her brother one evening, she felt her jaw sag and her knees buckle. Speechless, she just managed to maneuver herself onto a chair. This gripping depiction of narcolepsy was narrated by neurologist Adam Zeman in his excellent book, A Portrait of the Brain. Hello, I'm Ibrahim Imam and welcome to this episode of the Neurology Lounge podcast. In this episode, we will start our exploration of sleep disorders with a special focus on narcolepsy. In his book, Zeman takes us back to the first description of narcolepsy, which was in 1880 by Dr. Jean-Baptiste Édouard Gélineau, who reported the case of a 38-year-old barrel merchant who had fallen prey to sleep attacks. Zeman described these as irresistible naps which might overcome him as he spoke, in mid-sentence or during a meal, the knife and fork dropping from his fingers, or even at the theater. Zeman added that the merchant slept only briefly for a few minutes, waking refreshed, but noting that the attacks would take hold of him several times a day and were a source of increasing embarrassment. In addition, the merchant was also plagued by episodes of sudden weakness triggered by strong emotions and sudden changes of arousal, laughter, sadness, relief, anticipation. He said his knees might buckle, his chin drop, his head nod, and in a bad attack he would be unable to stay upright and crumple to the floor or would slip helpless from his seat. Occasionally, Zeman wrote, the attack might end in a short period of sleep. Gélineau had named the disease narcolepsy, and this was from the Greek for caught by sleep. And the name has stuck. Gélineau also named the peculiar episodes of weakness esthesia. This has not stuck. It was later changed to cataplexy, the Greek word for stupefied or struck down by terror. Zeman wrote that Gélineau was to go on to publish 14 more cases of the disorder, establishing him as the owner of this condition. But to get detailed patient perspectives of their lived experience of narcolepsy, we have to come closer to our own time. And one such example is the illness story of Corinna Wetzel, which she narrated in her book titled The Journey Beneath Her Heavy Feet. Wetzel recalled that her symptoms began in 4th grade, and it started with difficulty understanding and remembering what she was reading. As she began to read in class, she said, I quickly began to struggle to sit up straight. My body began to feel weak. I felt a heavy weight come upon my entire body again. I struggled to stay still, trying to keep upright. She said it wasn't long before I squirmed my way down, slouching in my desk, placing my head on my folded arm. I began to drift in and out of dreams of scenes in the book we were reading. Every couple of minutes, I would reorientate myself and snap back to slowly drift away again. As the school day ended, she said, I no longer had the strength to battle with my body. I fell asleep quickly and began to dream about the bell ringing and heading out the door. She eventually started falling asleep in other situations, such as when she was in a public hot tub full of people, where she said, "My eyes began to become heavy and my head continuously fell forward as I battled hard to keep my eyes open." She said, "I couldn't rouse the energy to get out, even as I desperately wanted to." And even when she tried, she said, "I was pulled back into a dark place before I could lift a muscle." As her illness progressed, she said she started craving sleep like a dangerous drug, and she started to plan naps into her day, sleeping in the stairways or bathroom stalls. Her night times were equally disrupted, as she said she may wake in the middle of the night and struggle to go back to sleep. She remarked that it was like I was fighting with sleep in the day and in the night, but with opposite enemies. By 10th grade, she said she realized that sleep was my worst enemy. It was completely taking over my life in every aspect. She added that each year my body was ripped of more strength and energy. I had lost all ability to control my sleep. Other narcolepsy symptoms that Wetzel subsequently experienced were cataplexy, when she would feel her legs giving out briefly, as well as frequent episodes of sleep paralysis. Wetzel adopted several behavioral techniques to deal with her excessive sleepiness. For example, she said, "I became a chatterbox in class because that is when my body felt the least heavy. It was the only way to fight my tired eyes." She also became disruptive for the same reason, something that got her frequently suspended from school. As a result, she also did everything to avoid going to school. Wetzel's story also illustrated the lifelong nature of narcolepsy. After high school, she started working as a manager in a KFC restaurant where she said team members would catch her sleeping in the office. And she also found that she had fallen asleep trying to count the cash register drawers, having to start over multiple times. And after she gave birth to her first child, she reported that she would fall asleep whilst feeding her daughter. She then resorted to coffee, which helped, and she also nursed her child at her mother's house as a precaution. Very sensible. The impact of narcolepsy on academic life, the phase at which most people will develop the condition, is also evident in Wetzel's story. And it is also a feature of the illness as experienced by Henry Nichols, which he narrated in his memoir titled Sleepy Head. Nichols was 21 years old and in his second year at university when he developed progressively worsening sleepiness. These would come up shortly after waking in the morning, and he likened this to a smog seeping into my brain and anesthetizing my faculties until I was left with no option but sleep. He said he initially tried to fight it, but that the constant struggle to prevent myself from drowning was almost worse. Nichols therefore said he came up with little tricks that would hold off sleep for a minute or two, pinching myself, running violently on the spot, shouting at the top of my voice, techniques he tried. But despite these measures, he said that the feeling would begin to creep up on me all over again. He realized that he couldn't function in a meaningful way, but he managed through to his degree by dribbling over lecture notes, dozing through tutorials, overdosing on caffeine to extend the fitful snatches of wakefulness I needed to make the grade. The clinical features of narcolepsy are fairly well defined and have changed very little from those documented by Gélineau in the 19th century. We, however, have a clearer understanding of the cardinal features as well as the risk factors. For example, we know that narcolepsy usually starts in adolescence with an onset age of 15 to 40 years. But as we shall see, it can affect much younger people. It is also slightly more frequent in males. Narcolepsy is also now classified into two types depending on the presence or absence of cataplexy, and these are type 1 and type 2 respectively. Cataplexy refers to sudden episodes of partial or generalized loss of muscle tone and this is typically triggered by such strong emotions as amusement, elation, or anger. Episodes of cataplexy last less than 1 minute, during which awareness is maintained. As a caution, cataplexy may be associated with limb twitching, making seizures a close mimic. Beyond cataplexy, the other three major symptoms of narcolepsy are excessive sleepiness, sleep paralysis lasting 1 to 2 minutes, during which there is an inability to move, and hallucinations either at sleep onset or awakening, called hypnagogic or hypnocampic, respectively. And then there is disturbed night sleep. Associated symptoms of narcolepsy include blurred vision, double vision, poor memory, and impaired concentration, all quite understandable. There may also be complex sleep onset movements which can involve different parts of the body. And beyond the clinical features of narcolepsy, the disease may also be associated with other sleep disorders, and these include sleep-disordered breathing, periodic limb movements of sleep, disturbed night sleep, sleepwalking, automatic behavior, sweet cravings, especially at night, micro-sleeps, vivid dreams, lucid dreaming, and delusional confusion of dreams with reality. There are also other non-sleep related disorders reported with narcolepsy, and these include chronic pain, obesity, schizophrenia, and, wait for that, increased creative thinking. Now, our exploration of narcolepsy will take a deep dive into what is really going on in the brains of people with the disorder. To understand this, we must go back to basics and ask what normally happens in the sleeping brain and how we got to know this. And our guides for this will be sleep experts Antonio Zadra and Robert Stickgold, who narrated the history of our first insight into the phenomenon of sleep in their book titled When Brains Dream. They take us back to one cold December night in 1951 when Eugene Aserinsky, a PhD student of sleep researcher Nathaniel Kleitman, who was recording the electrical brain activity of his 8-year-old son. This was when he noticed that his son's eyes periodically went into rapid movements, all the while his son being sound asleep. This led to the classification of sleep into rapid eye movement, REM, and non-REM phases. Zadra and Stickgold explain that during REM sleep, the brain's careful regulation of a host of bodily functions seems to go offline, and during this, the brain's electrical activity becomes chaotic, just like wakefulness. Furthermore, during REM sleep, they said muscle tone drops to near zero, and this was recorded by an electromyogram. What therefore happens in the normal sleeping brain is a sequence that begins with non-REM sleep, and this is followed by REM sleep, and this cycle recurs 4 to 5 times before wakefulness sets in again. According to Zeman, people with narcolepsy have an unusual fragility of the boundary between wakefulness and REM, states that are normally separated by a substantial period of non-REM sleep. Referring to Lucy, his patient with narcolepsy, he explained that this is why vivid images rush into her mind at the onset of sleep, because her brain is already into REM sleep while her mind is half awake. He also explained that this is why paralysis on waking from a dream occurs when REM atonia persists beyond the boundary of sleep. Zeman therefore concluded that narcolepsy results from a failure to segregate the states of consciousness normally. But why does this breakdown between REM sleep and wakefulness occur in the first place? The answer lies in low levels of hypocretin, a peptide that is produced by specific cells in the hypothalamus, and these cells are damaged in people with narcolepsy. The story of how narcolepsy became associated with hypocretin deficiency is also an interesting one, and it has been described as a dramatic example of the application of basic science techniques to the analysis of sleep disorders. Hypocretin was discovered in 1998, almost simultaneously by two research teams. It was first called orexin, after the Greek word for appetite, and this was because it triggered feeding when injected into the ventricles of the brains of experimental animals. This also explains why the early research in this field first investigated their role in the treatment of obesity. The animal studies, however, pointed to the role of hypocretin in narcolepsy when two research teams discovered mutations in the hypocretin gene in dogs with the disorder. It didn't take a long time to apply this finding to human narcolepsy, and it led to the eventual discovery by several research teams of a massive loss of hypocretin neurons, an average of 93% in the brains of people with narcolepsy. In other words, narcolepsy is a disease of hypocretin deficiency, and this is why the hypocretin levels are reduced in the cerebrospinal fluids of people with narcolepsy. Although the hypocretin deficiency we have just explored is a result of a genetic mutation, it is important to know that it can also be caused by acquired rather than genetic factors. Let's see how this played out in the case of Mathilda. She was just 3 years old when she started experiencing vivid dreams during which she cried out and thrashed around. She had also woken up hallucinating that a frog was on top of her. Narrating her story in the memoir titled Waking Mathilda, her mother, Claire Crisp, wrote that Mathilda also slept excessively during the day and became miserable, lethargic, and easily upset in school. As her mysterious illness progressed, Mathilda became floppy and unsteady, and she began to slur her words and to wet herself in sleep. Mathilda also had an episode of collapsing when, joyful in anticipation of playing a game, her knees gave way and she dropped to the ground like a bag of potatoes. Unfortunately, her symptoms worsened, and even after several visits to the hospital and after seeing several specialists, her condition remained undiagnosed. But just as she and her mother were about to refer to the psychiatrist, a visiting neurologist took the time to listen to her story and to review video recordings of her symptoms. These convinced him that little Mathilda, as young as she was manifesting narcolepsy with cataplexy. Mathilda's story is unique in many ways. The first was in the manifestation of narcolepsy at such a young age, indeed the youngest on record at the time. The second was in its cause, the H1N1 influenza vaccine. Claire Crisp writes about her eternal regret taking her daughter to receive the vaccine called Pandemrix in 2010. She did this following the guidance to vaccinate all children under the age of 5 years in the UK and between the ages of 2 to 15 in Europe. The vaccination was rolled out in anticipation of the 2009 H1N1 swine flu becoming a global epidemic. Pandemrix, Crisp wrote, was an adjuvanted vaccine which contained squalene, a chemical that helped to boost the immune system. Unfortunately for Mathilda and about 1,500 other children, Crisp said the vaccine destroyed hypocretin cells by an uncertain mechanism. She said all the symptoms of narcolepsy and suffering crystallized in the seconds it took for Mathilda to receive the vaccine. Concerningly, Crisp pointed out, the vaccine had not been tested in children prior to its rollout, and clinical trials had not been completed to an adequate level of safety before it was launched. Whilst Mathilda's unfortunate case highlights a regrettable acquired trigger for narcolepsy, it is nevertheless a rare one. More likely, the causes of so-called secondary narcolepsy are such disorders as brainstem stroke, brain tumors, cranial radiation, encephalomyelitis, disorders of the hypothalamus and pituitary, traumatic brain injury, multiple sclerosis, and a host of neurodegenerative brain disorders. Narcolepsy is notoriously difficult to diagnose when it does not manifest with its full clinical profile. This is why, quite often, many other disorders are considered before the diagnosis emerges. Amongst the main narcolepsy mimics are disorders that also cause excessive sleepiness, and these include just having a poor night's sleep, and also things like obstructive sleep apnea and circadian rhythm disorders. And to top the list is idiopathic hypersomnolence, that is excessive sleep of no known cause. Seizures, fainting, head injury, and a host of medications such as hypnotics can also mimic the excessive daytime sleepiness of narcolepsy. There's also a list of disorders that mimic cataplexy, and these include Niemann-Pick disease type C, functional seizures or pseudo-cataplexy, and a rare condition called stimulus-induced drop episodes or SIDS, which is seen in an equally rare disease called Coffin-Lowry syndrome, one for the medics. To try and unravel her diagnosis, Mathilda underwent many tests. For example, she had an MRI scan to look for a brain tumor, a sleep study to investigate for sleep apnea, and an EEG to rule out suspected epilepsy. When the diagnosis of narcolepsy was considered very likely, she had narcolepsy-specific tests, which included a blood test for the HLA-DBQ1 genetic marker of narcolepsy risk. It was positive in Mathilda. Mathilda also had a multiple sleep latency test, which was inconclusive. A positive MSLT would have been that she fell asleep within 8 minutes and went straight into rapid eye movement sleep on 2 or more of the testing periods. These are called sleep onset rapid movement periods or SOREMs. Mathilda's doctors also considered checking her spinal fluid to see whether her hypocretin level was low. They, however, rightly thought that this was unnecessary because it was an invasive test that would not have altered her management. If she had had the test, a positive hypocretin result would have been a value of 110 picograms per mil or less. Unlike many other neurological disorders, narcolepsy has a range of treatments for its different manifestations. The first line is the treatment of excessive sleepiness, also called hypersomnia. The traditional first-line agent used here is modafinil, but the introduction of sodium oxybate is shifting the balance because this is also effective in treating cataplexy and in treating disturbed night sleep. In severe cases, the two can be combined. Other treatments of excessive sleepiness include amphetamines, selegiline, mazindol, solriamfetol, pitolisant, and modafinil. I've never used any of these. Next are the treatments of cataplexy, which, apart from sodium oxybate, include the tricyclics clopimipramine and protriptyline, the SSRIs femoxidine and citalopram, and the SNRI called venlafaxine. To review the patient perspective of narcolepsy further, I will be speaking to Julie Flygear. She is the author of a memoir titled Wild, Awake and Dreaming, and she narrates her experience of the disorder in that book. Thank you very much for listening to or watching this podcast in which we explored narcolepsy. Apart from the books I have already cited, I've also relied on the following source for this podcast. This is by Siegel and colleagues titled A Brief History of Hypocretin/Orexin and Narcolepsy. This was published in 2001. If you found this podcast enlightening or helpful, you may consider reading my book called Surfing the Brain, where I explore more of neurology in a similar way. And if you want to know more of the nitty-gritty of narcolepsy, then you might want to check my website, Neuro Checklist. And to make sure you do not miss the next episode of the podcast, why not subscribe to the iTunes, the Spotify, or the YouTube channels? Until the next episode, thank you very much for your time.